Opioids toxicity and withdrawal. Opioids is a term for a number of natural substances, originally derived from the opium poppy, and they're semi-synthetic and synthetic analogs that bind to specific opioids receptors. Opioids, which are potent analgesics with a limited role in management of cough and diarrhea, are also common drugs of abuse because of their wide availability and euphoriant properties. There are three main opioids receptors: delta, kappa, and mu. They occur throughout the central nervous system, but particularly in areas and tracts associated with pain perception. The receptors are also located in some sensory nerves on mast cells and in some cells of the gastrointestinal tract. Opioids receptors are stimulated by endogenous endorphins, which generally produce analgesia and a sense of well-being. Opioids are used therapeutically, primarily as analgesics. Opioids vary in their receptor activity, and some, for example, buprenorphine, have combined agonist and antagonist actions. Compounds with pure antagonist activity, for example, naloxone, naltrexone, are available. Efficacy of opiates: full agonist. Morphine, meperidine long-acting, methadone, codeine, fentanyl. Partial agonist. Buprenorphine, mixed agonist-antagonist. Butorphanol, nalbuphine. Antagonist naloxone, naltrexone, methylnaltrexone. Opioid receptor agonist for the treatment of diarrhea. Loperamide diphenoxylate. Opioids tolerance develops quickly, with escalating dose requirements. Tolerance to the various effects of opioids frequently develops unevenly. Heroin users, for example, may become relatively tolerant to the drug's euphoric and respiratory depression effects, but continue to have constricted pupils and constipation. A minor opioid withdrawal syndrome may occur after only several days' use. Severity of the syndrome increases with the size of the opioid dose and the duration of dependence. Long-term effects of the opioids themselves are minimal. Even decades of methadone use appear to be well tolerated physiologically, although some long-term opioids users experience chronic constipation, excessive sweating, peripheral edema, drowsiness, and decreased libido. Acute opioid intoxication is characterized by euphoria and drowsiness. Mast cell effects, for example, flushing, itching, are common, particularly with morphine. Gastrointestinal effects include nausea, vomiting, decreased bowel sounds, and constipation. Toxicity or overdose. The main toxic effect is decreased respiratory rate and depth, which can progress to apnea. Other complications, for example, pulmonary edema, which usually develops within minutes to a few hours after opioid overdose, and death result primarily from hypoxia. Pupils are myotic. Delirium, hypertension, bradycardia, decreased body temperature, and urinary retention may also occur. Normeperidine, a metabolite of meperidine, accumulates with repeated use, including therapeutic. It stimulates the central nervous system and may cause seizure activity. Serotonin syndrome occasionally occurs when fentanyl, meperidine, tramadol, methadone, codeine, or oxycodone is taken concomitantly with other drugs that have serotonergic effects. For example, selective serotonin reuptake inhibitors, monoamine oxidase inhibitors. Serotonin syndrome consists of one or more of the following: hypertonia, tremor and hyperreflexia, spontaneous, inducible, or ocular clonus, diaphoresis and autonomic instability, agitation, temperature greater than 38 degrees, plus ocular or inducible clonus, withdrawal. The opioid withdrawal syndrome usually includes symptoms and signs of central nervous system hyperactivity. Symptoms may appear as early as 4 hours after the last dose, peak within 48 to 72 hours, and subside after about a week. Anxiety and a craving for the drug are followed by increased resting respiratory rate, usually with diaphoresis, yawning, lacrimation, rhinorrhea, mydriasis, and stomach cramps. Later, piloerection, tremors, muscle twitching, tachycardia, hypertension, fever and chills, anorexia, nausea, vomiting, and diarrhea may develop. Opioids withdrawal does not cause fever, seizures, or altered mental status. Although it may be distressingly symptomatic, opioids withdrawal is not fatal. The withdrawal syndrome in people who are taking methadone, which has a long half-life, develops more slowly and may be less acutely severe than heroin withdrawal, although users may describe it as worse. Even after the withdrawal syndrome remits, lethargy, malaise, anxiety, and disturbed sleep may persist up to several months. Drug craving may persist for years. Diagnosis of opioid use is usually made clinically, and sometimes with urine drug testing. Laboratory tests are done as needed to identify drug-related complications. Drug levels are not usually measured. Opioid toxicity or overdose treatment. Treatment to maintain the airway and support breathing is the first priority. Patients with spontaneous respirations can be treated with an opioid antagonist. Naloxone has no agonist activity and a very short half-life. Naloxone rapidly reverses unconsciousness and apnea due to an opioid in most patients. Sometimes endotracheal intubation may be needed. Opioid withdrawal treatment. The opioid withdrawal syndrome is self-limited and, although severely uncomfortable, is not life-threatening. Minor metabolic and physical withdrawal effects may persist up to 6 months. Withdrawal is typically managed in outpatient settings, unless patients require hospitalization for concurrent medical or mental health problems. Options for management of withdrawal include allowing the process to run its course cold turkey after the patient's last opioid dose and giving another opioid substitution that can be tapered on a controlled schedule. Opioid withdrawal treatment. Medication-assisted treatment with buprenorphine partial opioid agonist and naloxone opioid antagonist has become the primary choice of treatment. Naloxone is added to buprenorphine to reduce abuse potential. When taken sublingually, the buprenorphine opioid agonist effects predominate, reducing withdrawal symptoms. Methadone long-acting opioid agonist is given orally in the smallest amount that prevents severe, but not necessarily all symptoms of withdrawal. Clonidine, a centrally acting adrenergic drug, can suppress autonomic symptoms and signs of opioid withdrawal. Opioids are euphoriants that cause sedation. Respiratory depression may occur with high doses and can be managed with antidotes, for example, naloxone or endotracheal intubation and mechanical ventilation. Withdrawal manifests initially as anxiety and drug craving, followed by increased respiratory rate, diaphoresis, yawning, lacrimation, rhinorrhea, mydriasis, and stomach cramps. And later by piloerection, tremors, muscle twitches, tachycardia, hypertension, fever, chills, anorexia, nausea, vomiting, and diarrhea. Diagnosis is clinical, plus with urine tests. Withdrawal can be treated by substitution with a long-acting opioid, for example, methadone or buprenorphine, a mixed opioid agonist-antagonist,